The stars are bright, we own the night. The stars are bright, we own. The stars are bright, we own the night. The stars are bright, we own. The
I am well. I am so happy to be here with you.
Thank you. I'm so happy that you're here. I'm excited about today's conversation.
Yay.
I know we're not going to get through everything, but we're going to do what we got to do.
Yes, ma'am.
Yeah.
And I'll say happy Myeloma Awareness Month to you and everyone who will be joining us there. Or Myeloma Action Month. I know some people say Myeloma Action Month. So, yeah.
The same to you as well. It's a tricky month because some of us really don't know about it, only within, I guess, our community. But that's a whole other conversation. That's another show. Hello.
Yes.
So, thank you for joining. I think we're going to get started because we do have a whole lot of stuff that we want to cover this evening. So as I'm doing this, as I always ask my guests, how was your day? We'll start it that way while I look for what I'm looking for.
It's pretty good. It was a typical Friday. I had a visit with the doctor today. It went pretty well. Yeah, so it was good. I can't complain.
Very
good. Got home, made a quick meal, and I am here.
Yay! Perfect.
It's a little chilly outside, so I'm waiting for the spring to get here. Spring has not sprung here. We're supposed to get snow tonight and into tomorrow. I'm sick of the snow. I'm ready for it to be gone.
Yeah, I'm kind of over. I'm not really a summer baby. However, I'm over it. Because I'm constantly, I feel like this winter specifically, I'm constantly getting sick. So that's not good. Like right now, I'm a little congested and all of that. So,
yeah, we have to be careful. We
really do. We really do.
Yeah. I saw this thing on social media a couple of days ago. It's like, I am ready for the summer to get here so I can stop complaining about winter and start complaining about the heat. So, it's just a trade-off.
You damned if you do, you damned if you don't. Because I know a lot of people who are like, oh, it's too hot. And then, oh, it's too cold. Like, come on now. You don't know what this summer's going to be, to be honest with you. It could easily be like 200 degrees for all we know. You know what I'm saying?
You pick one and you go with it. That's all you can do.
That's all you can do. So, thank you everyone who's on, for those who come on later when we do the replay. My name is Yolanda. I'm the host of No Better Time Than the Present. And today we have a special discussion for Myeloma Action Month. Okay, so I have the pleasure of having Miss Valarie Traynham. Okay.
Hi, guys.
And she has been, well, first let me just start off here. I'm going to have Valarie as a guest later on in the year, so that way we can hear a little bit about her story. But today we're kind of going to do a deep dive in another direction. But I want to give you a little bio about Valarie. Okay, so Valarie has been on the myeloma journey since 2015. And as a cancer thriver, which I love that representative of that, term, her goal is to learn about the disease, to educate others, and bring light to the health inequity that exists for myeloma patients. She wants to use her voice for those who cannot speak up for themselves to ensure that that they receive equitable access to good health care, which we all need,
Yeah.
clinical trials, and proper treatment.
Yep.
She is passionate about teaching others how to be their own best advocate. So bravo to you.
Yeah. Yeah. That's what it's about. That's what it's
That's
about.
what it's about. You know what I'm saying? So today, everyone, we're going to talk about what they don't tell you about multiple myeloma and what you really need to ask. Okay. And it was something that I was thinking about because based on a lot of the conversations that I've had with some very beautiful guests, the last one with Mr. Dion Langley, a lot of things he said, even though his situation is different from multiple myeloma, some of the things he said, it was something that could be relatable to people with multiple myeloma. So I wanted to do this special presentation as it is MAM month, or that basically wrapping up because like the April will be here like in a couple of days. So I wanted us to kind of take a little deep dive and explain a little bit and to also express that we're not all the same. And I think for a lot of people, sometimes when you're diagnosed with anything, but specifically with, focus on multiple myeloma, you hear the words, you hear the term. Usually you don't grasp it. However, if you look at a lot of the stats that are still up there talking to me old stuff, that whole 5-year lifespan, once you're in it for a bit, again, we're all different. Our journeys are going to be different. We get that. But I think for a lot of people, especially newly diagnosed, there has to be an understanding that we're really not the same. We're not all the same. So our journey is going to definitely be somewhat different. Okay. So what I wanted to do, along with Valarie, to start off like the initial conversation of 3 terms. Not really terms, but things to think about. So the first one is may or may not include what stage you are. Like, so when you're speaking to your doctor and you've just been diagnosed with multiple myeloma, do they really tell you what stage you're in? Okay, so for those who are myeloma warriors, okay, we know that there's 3 stages, but I think for a lot of people, when newly diagnosed, you don't even know, like, okay, what does this mean? Like, you tell me I have this, but is this like the tip early on, or is this like terminal? You know what I'm saying? So do you want to speak a little bit
Yeah.
more on that?
Yeah. So I think a lot of people, when they think of staging, when they hear cancer, that's one of the first things they kind of think of. What stage is it? And they think automatically the higher the stage, the worse the disease. Most people think, oh, if it's a stage 3 or stage 4, I'm going to die. It's just that bad. And one thing that most people don't realize that myeloma only has 3 stages.
Right.
And if you're at stage 1, it's kind of a lower risk disease. You have a lower burden of the disease that's within you. But a lot of times the doctors don't go into that, or a lot of times the patient may miss that because when you hear those words, you have multiple myeloma or you have cancer, the rest of it is just like blah 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 blah.
It
So
is.
you don't even remember what he said if he or she did say what stage it was there. Um, but I think that's important to know, and I think you need to know what the stage is, so you can know when it comes to treatments. If you are stage 1 and it's very minimal disease versus stage 3 where it may be high risk disease. I mean, you're going to have to look at what that boils down to when it comes to treatment options and things like that.
Right. I totally agree. And, you know, just as you say, sometimes these initial conversations is a blah, blah, blah scenario. But I think for those, once you're in it for a tag, you kind of realize like the questions to ask when it does come to staging, just in case your doctor has not expressed exactly what area, what stage you're in.
Mm-hmm.
So based on the 3 stages, what I had looked up, I know like the call outs into what level you may be in based on, you know, those lab results that we get. So if you're globulin, okay, I know they look at that in your albumin levels. If those, based on, I didn't even like do the whole, if it's under this and over this, I know that's kind of where they kind of, the doctors really spiral into exactly where you're at. You know, if you're a dieter or if you're watching weight, which that's the next conversation we're going to have. So, and part of those tests is part of a term called Dewey-Salmon. I hope I said that right.
Yep.
Or Dewey-Salmon, something to that degree. So that's part of the whole staging process. So another thing that the doctor may not stress, which we're going to talk about as well in terms of the types of doctors, okay? Because when we speak about the types of doctors, if it's a myeloma oncologist specifically, they will use the terms that we kind of want to hear, if that makes any sense. So part of the conversation may not stress how long is a watch and wait. Like if you're being told that, oh, your myeloma is in there, but it's not active. You know,
Maybe
if
if you're
it's
in a
smoldering,
small.
exactly. So it may be a process of, okay, we need you to watch and wait, which is kind of a weird term.
Yeah.
You know what I'm saying? Because, okay, so are we waiting for me to die? Like, exactly what are we waiting for?
Yeah.
So I know that can be a little not sure, you know, what that whole thing is about. So do
It
you
can be
want to speak?
scary. Yeah. So
It is.
it can be scary for a lot of people, and it can make a lot of people very anxious. I talked with a lady on yesterday, and she was very upset. She said, you know, I'm watching and waiting. What am I watching and waiting for? You know, I don't want this to warp into multiple myeloma. I want to do something about it now.
Right.
And then I also talked with another young lady who she didn't want to do anything. You know, her doctor was telling her, hey, this is smoldering, you're high risk. I think we should start some treatment. And she was like, I don't want to. It's not myeloma. I'm not ready to make that move just yet. So it really depends on the person.
Right.
Because you know, one lady was looking at the quality of life. She is really on top of what's going on, and she really understands what that looks like, because this is one of the things they don't tell you. When you start treatment, it's an ongoing process.
Right.
You know, it's treat until disease progression or until, you know, you can't stand the drugs anymore. And that's something they don't tell you when you're first diagnosed. So I commend her. She had did enough research to know that she wasn't ready to start treatment because she wasn't ready to go down that path yet. But it's still a little scary, you know, knowing that you have high risk smoldering and you're not willing to do anything about it. But that's a personal choice, you know, that one has to make that decision on their own there. So
it's interesting because I think a lot of times, especially with this disease, a lot of the process of learning and understanding is a process. You know, some things you're not going to know off the bat. You know, however, with that said, what they don't tell you, part of what tonight's topic is sometimes your doctor doesn't give you the full package of what the whole experience is going to be. It's either, oh, you got to start treatment right away, or in this case, oh, it's a watch and wait.
Mm-hmm.
But again, the term is kind of, it pushes you off because, again, well, what am I waiting for? For those who do want to start treatment, because I know of someone who had multiple infections, you know, and it was thought of maybe it was based on myeloma or what have you. However, the doctor was like, oh, it's watch and wait. So this person was like, okay, just as we said, well, okay, what are we waiting for? Because obviously, if I'm having all of these infections, why don't we just start the process?
Yeah.
So it's the whole logistics and terminology that can throw you off. But I think as the patient, this is where you really have a healthy conversation with your healthcare team to explain it. Like, exactly why do we need to wait this out?
But I think also, Yolanda, that's where it comes in. You have to have a specialist
Yes.
because even as when you're watching and waiting, it's very good to have a specialist on your team because they can tell you something that maybe your local oncologist is not up on. They may not know this particular bit about myeloma because they don't, that's not their, I'm not saying area of expertise, but you know, if you only see 5 or 10 myeloma patients a year, you may not be up on the latest of what's going on with them. Whereas if you're seeing a myeloma specialist, they know what's going on and they can kind of guide you in a better way than just say somebody who you know sees just a few myeloma patients. So even if you're smoldering, I definitely encourage you to see a specialist. Have that person on your team. And if it were me, if I were smoldering, I would want a specialist on my team. Uh, if they told me to watch and wait, I would feel a little better while I'm watching and waiting than if somebody who didn't have that knowledge about the disease told me just to watch and wait.
Right. I think, as I said before, with my story, I saw a hematologist. So the hematologist was like, oh, boom, you got to start this treatment right away. However, as I've said before, I was diagnosed in my 30s. Okay. So a lot of his patients did not look like me. And yeah, it would make sense that he would refer his other patients to start treatment like right away. So for me, I think he just kind of put me in that box with other people who are of a mature age. You know what I'm saying? So that was my red flag as to, okay, we need a second opinion. With that second opinion is when, after looking at the test results and then having to do some test results again because he didn't really do everything he was supposed to do. Yay, you're telling me to start treatment. After the second, but you know, pair of eyes looking at the situation, it was like, okay, you have smoldering myeloma. I was like, oh, okay. So it just tells you here's a hematologist versus a multiple myeloma oncologist. You know what I'm saying? So even though they're kind of in the same area, it does make a huge difference. Like, you know, it's like really a no-brainer, but I know that's easily said and done because some people truly don't realize that. You know what I'm saying? Yeah. So I wanted to speak a little bit, okay, part of like that initial conversation, again, with your doctor, okay, boom, you have multiple myeloma, blah, blah, blah. okay, they may not take into consideration the account, like how I mentioned about the age of the patient. Now, in my experience, the first doctor that I had was perplexed. First off, to see me walking through his office, um, and based on his experience, he felt that the best route would be to start treatment, which wasn't the case. So, though the data represents individuals in their 70s and 80s who are affected with multiple myeloma, there are a small percentage of people not in that box. You know what I'm saying? So you have people in their 20s, even though they're a smaller percentage and it's rare, they're out there. You know what I'm saying? And then you have those who are under 60, which I think now that's probably like a medium level in terms of, okay, if you say someone in their 70s and 80s, this is like a cancer that affects that age group. I think it can be fair to say, I don't know how accurate that data is, because you have people in their 30s, their 40s, and their 50s. You know what I'm saying? So you have those under the 60 realm. So, though if you are diagnosed at an earlier age, it seems based on what I was looking at, the consensus is you may have a better go at it in terms of treatment and maintaining this disease. So what is your take on that?
Yeah, yeah. The research is showing that, even though you're diagnosed at a younger age, with the current treatment options that's available, um, people are living longer with multiple myeloma. I mean, there's no doubt about that. The median survival when I was diagnosed 8 years ago was 3 to 5 years. I
Mm-hmm.
mean, that's more than triple now.
Right.
So people are living longer. Novel therapies. We can attribute that to novel therapies that's coming out. Um, Yes, diseases are being caught earlier, not in our population, not in the African American population, because we're still facing delays in diagnosis.
Right.
But once we are diagnosed and we get that same care that our white counterparts are getting, we do just as well, if not better, and we are living longer with this disease.
Mm-hmm.
So uh, that is true. There have been so many advancements within this disease arena that people are living longer. Even in the elderly population, people
Right.
are living longer with the disease. Even without stem cell transplant, the
Mm-hmm.
quad therapies are showing so much potential now that, for those frail patients who are not able to withstand the stem cell transplant, they are seeing good results with the quad therapies.
Right.
Yeah, yeah, great results.
Like, it's funny because I think I've mentioned, um, over time, I feel like with this particular disease, maybe we'll get to that point where it'll be 100% in terms of, wiping it totally out.
Mm,
I feel hopeful, based on the many years that I've kind of been in a struggle, to kind of see what was offered in the beginning to where we're at now, where we have like all of these options. You feel like, oh, okay, this is a good thing, because I think we all want some type of options, out there. You know what I'm saying?
yeah, I I think, and I use the C word. I think we will see a cure for myeloma.
Mm-hmm.
I hope it's in my lifetime. I think it's going to take a lot, though. Um, I think what's kind of holding us back from a cure is us. And when I say us, I go back to the Black population. We don't
Okay.
participate participate in clinical trials, you know, and we have reasons, they're valid reasons. But in order for there to be a cure, we have to be a part of that. You know, these medications, these novel therapies are coming out, they're doing great things for myeloma patients, but are they doing great things for all myeloma patients or a subset of the population? And that's what we have to take in consideration. In order for us to really get advanced and get further down the road, we're going to have to come together as a whole, and that means everybody is going to have to come together, and we're going to have to make sure that these treatments that we're coming up with work for everybody across the board. And right now, that's not happening, you know. So
Right.
I think
Like,
it
of
will
course,
happen.
we want to see at the table, because we can't have a cohesive conversation if the balance is not there,
Yeah, yeah,
in terms of who's affected or the outcome of it.
yeah.
Maybe those the data and statistics can actually change if everybody is included. And I know we're going to speak a little bit about the clinical trials a little further in. So I wanted to, delve from the whole initial conversation with your doctor.
Yeah.
So I wanted us to focus on those individuals who are in their 20s and their 40s. Okay. Now, it's not a perfect script, unfortunately, how you're diagnosed, when you're diagnosed, if the doctor picks up on certain things on your lab to even make a call out. Unfortunately, it's not a perfect scenario, But for the people in their 20s and 40s affected, again, it's something where certain things we tend not to ask, rightfully so, but we tend not to ask, and those are things that can affect our lives by not asking, because again, it isn't a proper script as to call outs that your doctor should be talking about. So sometimes, again, this is where the patient advocacy comes in, where, oh, well, maybe let me ask about this, because they may not volunteer the other stuff a 20 through 40-year-old may want to know, how is this going to affect my life?
Yeah.
Okay. So one thing I wanted to discuss was fertility. Okay. Now, if you're a 20-year-old, you may want to have children. Maybe you don't. Maybe whatever's whatever. But when you're diagnosed, maybe that's no longer on the table. So like I said, it's not a perfect script, and this is where you have to be vocal. And if the doctor doesn't know, okay, if you got a good doctor, they will then refer you to possibilities or who you need to speak to.
Yeah.
So where I'm going with this is some of the conversations that may not be put out there is, for a woman, maybe think about freezing those eggs. Okay, because if you do have to get in treatment, if it is a watch and wait, let's say if your watch and wait is 10 years, which that's a good stretch. Okay, 10 years. Obviously, when you start the treatment, that's a wrap. Like, if you get to a complete remission, that's a good thing. Maybe there is time for you to visit this whole thought process if you do freeze your eggs.
Yeah.
Another thing is, like I said, speaking to the proper specialist. If your myeloma oncologist doesn't know and seems clueless, especially for a 20 through 40-year-old, okay, doc, I need you to get with it. If they don't know, they should be on board as to refer you to who you need to speak to. And then lastly, just an openness to other options. You have surrogacy, you have adoption, you have foster care, you have all of these things. And though for some people, I guess it's these kind conversations are taken for granted because maybe that's not a call out because you're trying to survive.
Yeah.
However, it really is important because if you do treatment and you're someone who is young, who wants to have children, right? And let's say you go through the whole proper treatment of this therapy and that, and let's say you do get to complete remission, and some of those options that I mentioned may no longer be on the table. Some still are, but some are not. So what is your take further in terms of this whole fertility?
Yeah. So I think as a someone between the ages of 20 and 40, receiving a cancer diagnosis, it's something that we probably don't think about because, you know, you're in shock and you just want to get treated and you want to get well so you can get on with your life. Um, I do think it's something that needs to be part of your treatment plan. Um, I know I was 42 when I was diagnosed, and I did not hear anything about fertility. Now, there was still a chance that I could get pregnant, and but it was not something that was ever put on the table. I didn't think to ask about it because I was thinking about living.
Right.
So I do think it's something that needs to be tight. I think it needs to be part, like I said, of any care plan that your oncologist is talking to you about. But I think as young people, that option needs to be available. Whether it's the freezing of the sperm, the freezing of the eggs, whatever it may be, I think those options need to be discussed. Um, whether it's adoption or surrogacy, whatever it is, I think it needs to be put out there before any kind of treatment starts. Because once you start treatment, I mean, it greatly reduces the chances of
Right.
the sperm and the eggs. It greatly reduces the chances of them being viable in the future. So I really think that those things need to be talked about, and they just aren't. Um, and it may be just that busyness of, hey, let's just get treated, let's just get you well. Um, and it may be one of those things where people are ashamed. I don't know how to bring this up, to my doctor. It may be, hey, this is not something I need to be worried about. I need to be worried about getting well and living. This is something that I can worry about afterwards. So it's just a combination of things when it boils down to it. It could be any one of those things, but I think it needs to be, as I said, if it's part of the care plan, if it's part of your treatment plan, we're going to talk about this up front, then it eliminates it. It takes all of that stigma out of it. It takes all of the embarrassment. It takes all of the shame out of it to where it's like, hey, it's just like anything else. It's just like any other side effect. We're going to talk about it. This is what could happen. You need to be aware of this is what could happen, and this is how we're going to do it. This is an option that you have. Yeah.
I totally agree. I think, I know I've said this before, like so many things. I keep saying I feel like a broken record, but I think it's so important if, like I said, it's not a perfect script. So if your doctor or whoever doesn't give you the playbook, okay, somewhere has to be a social worker. So if you're in a hospital facility, there's different types of facilities to get your treatment, find these myeloma oncologists and what have you. Somewhere down the line, somebody should be, okay, well, if the doctor, he's trying to help save your life, if you need further direction, I think every patient should be provided a resource in terms of a social worker. Now, I know in my case, I had to actually find the person because I don't play, okay? And that wasn't initially available for me. And then when I sat and thought about it, like, shouldn't I be speaking to a social worker?
Mm-hmm.
Shouldn't I be seeing a nutritionist? Now that's just me. Like I said, I can be different from like the general public, because for me, I'm going to ask a question. You know what I'm saying? But yeah, I
You
think
have that knowledge, but the average cancer patient
exactly.
wouldn't think, they just don't think like that. And here, I want to go back for a second. When I was diagnosed with a myeloma, that was not the case. But when the breast cancer diagnosis came along, there was a lady on my medical team that, she kind of approached me about that. And I kind of joked with her about it. I was like, you know what? All of that stuff, I lost all of that stuff when I had the transplant. I wish somebody would have talked to me about it at that time. But I appreciated that she did try to talk to me about,
Right,
fertility and stuff like that. But I'm like, you know what? It's just a little bit too late. But
right.
I was glad that it did happen. So I know that it does happen at some facilities, but it doesn't happen at all
At
facilities.
all.
And it needs to be at all facilities, regardless of where you're at. It needs to be there.
I believe that one day we will get there, because the balance beam is not balancing,
Mhm.
in terms of the information that's out there, and
Mhm.
not everybody getting it, and everybody's kind of all over the place.
Mhm.
You know what I'm saying? Um, okay, to switch gears
Mhm.
a little bit, again, for those in their 20s and 40s, and maybe those older. Um, Another thing, and I don't know, maybe the doctor won't go too much in details, but career changes.
Mhm.
We know once you start some of these meds, some people, the toxicity of it is a bit much. Some people have to quit work, get on disability if they can get on disability, which it can be a stretch, because now you got to prove certain things, you got to get paperwork. I don't know how that whole thing is, because I've never had to apply to that. Thank God I was able to continue working and doing what I had to do. And just, it was tough.
Yeah.
Don't get me wrong, I'm not trying to say I was superwoman, but I was like, yeah, I can't let this mess up my money. You know
Yeah.
what I'm saying? So it's
Right.
like, let me just go to this bathroom over here, take a deep breath after this treatment. And, you know what I'm saying? So, but some people, if you have the neuropathy, all of these different side effects that
Yeah.
come about. Um, so, okay, career changes.
Mhm.
If it's not the disability, okay, maybe the conversation is being open to your employer
Mhm.
about, this is what I have going on. Maybe this is a conversation with HR
Mhm.
or your manager, depending on where you're working or what have you. So my thing is, remember that there is a federal law out here in the good old United States
Yeah.
of the ADA, which is the American Disability Act. So seeking disability, um, it's an option,
Mhm.
and but then you have to think, is it enough to help you pay your bills if you decide to get on disability?
Mhm.
Now, part of this conversation too, I know I wrote like a little, I can read this. Protects eligible cancer survivors from discrimination in the workplace, requires eligible employers to make a reasonable accommodations to allow employees to function properly on the job. Accommodations may include modifying work schedules, reassigning an employee to less physical taxing position, or providing a more comfortable chair, all of these accommodations.
Yeah.
However, okay, we know, again, depending on where you work in and all of that, it can be a very slippery slope. And again, this isn't really a doctor conversation. To me, I feel like a career conversation when you're diagnosed, maybe a social worker, because maybe they will have a better ear on, on this topic. But it's tricky because I would think when you're so open to tell HR some of your business, or you're open to tell your manager or your coworkers, and then based on what I just read, are a lot of people open to, oh, she needs a special chair, oh, she needs to go into the restroom because she just had treatment. After a while, people are going to just treat you somewhat differently.
Yeah.
Do you agree?
I do agree, but I'm going to say this. This is one of those things that the realities of cancer that you're not told about when you're diagnosed. When we first started this conversation, this is one of those things. But I also think a lot of times people are afraid to ask for an accommodation, because of for whatever reason. When it's something very simple that it won't cost the employer anything to do, but they just won't ask because of fear. When it comes to career changes, I think a lot of times it's inevitable when it comes to a cancer diagnosis, whether it's multiple myeloma or anything, simply because the side effects of the medication, the chemo brain, like you mentioned, the neuropathy and things of that nature. You just cannot continue to do what you used to do, particularly if you had a job that was physically demanding. You can't keep up with those, that I say manual labor, But for some people, it's a choice, It's like a new opportunity. Hey, you start looking at things. I was never happy doing what I was doing. This is a new opportunity that I've been given. I'm going to look at it from a different lens, and I'm going to do what I've always dreamt about doing. So you can look at it from two aspects. You can look at it from, hey, I'm going to start a new career path and I'm going to do what I want to do. Or you can say, hey, I'm going to go in here. I'm going to tell this HR person what they need to know to allow me to get this accommodation. Because a lot of people think that you have to tell HR everything and you have to tell your employer everything. You don't have to tell your employer everything.
Nope.
You go in there, you fill out that paperwork asking for an accommodation. That's what you have to do. You don't have to tell them, hey, I got cancer, I'm experiencing this, and this. And, my doctor said, you don't have to do that. According to the law, you don't have to do that.
Exactly.
When that paperwork is sent over to your doctor, it's certain things that they are obligated to put on there. And it's certain things that they can't put on there, describing your diagnosis and stuff like that.
Right.
People need to be educated about that. And I think that when they are educated about that, there will be less fear about going into HR and asking for an accommodation. When you know what you're entitled to, you go in there and you ask for it with your head up. And you don't take no for an answer because you're entitled to it. And I think people don't do that because they just don't know.
Right.
So we have to, again, it's all about educating people about what is theirs.
It's true. And I think this is a perfect conversation for Myeloma Action Month. Okay. Notice the second word, action. Okay. So if you didn't know, okay, now these are things to let it marinate, to consider, I wanted to add, like, as a resource for those who are, whether they're re-entering into a career after post on cancer or what have you. We have Cancers in Careers, which is a great resource. They have a lot of webinars on how to do X, Y, and Z. It's just like a good resource to consider to, you
They had
know,
their Midwest workshop today. I listened to half of it this morning before I went to my appointment, but they are
okay,
very good research. That's where I learned a lot of my stuff when it comes to cancer and working and stuff like
right.
that. Great resource there.
That's definitely a great resource for those who want to continue working.
Mm-hmm.
And again, like I said, or get back into whatever their career or whatever was. Um, so to continue again conversations with the 20 and 40-year-old,
Mm-hmm.
we spoke briefly. I guess we don't have to marinate too much because I kind of want this to wrap up and get to some other things. But we did speak about the differences between the specialists
Mm-hmm.
and how important it is for, or the differences between a hematologist and a multiple myeloma specialist. So just to kind of give a little definition, a hematologist is a healthcare provider who specializes in diagnosing, treating, and managing diseases that affect your blood and your bone marrow. A myeloma specialist, though both can do the same, a multiple myeloma specialist slash oncologist would be more privy and trained on the steps to follow to treat multiple myeloma. So I say that to say, when you're making a cake, I don't know if that's good again, you're making a cake from scratch, you
Uh-huh.
know, and okay, do you want, I don't know, do you want your grandma, who is like the baker in the family, to show you how to make a cake? Or do you want, let's say, your mama, who is not a baker, and probably don't even want to cook? It's like everybody relies on grandma. Then think of it as this example here. Okay, you
Mm-hmm.
want the best
Yeah.
in saving your
Yeah.
life. So if you're telling me the hematologist, he know about a multiple myeloma. Perfect example again, back to me. Here this hematologist, oh, well, I'm going to just put you, this young person, I'm going to just put her in this box over here, like all of my other people. And no. So you're not the best fit for me. Okay,
Mm-hmm.
I need somebody specifically who is focused on this particular disease and what are my options, really fine tuned and geared into what we're talking about.
Yeah.
So think of it that way. You
Mm-hmm.
know what I'm saying?
Yeah.
So I'm going to just get off of that because we already put some time on that. So
Yes. Get a specialist on your team. That's the
we got,
most important thing is to get a specialist on your team.
you know what I'm saying? To the point, cut and dry.
Yeah.
Okay, so we spoke a little bit about clinical trials. I
Mm-hmm.
wanted us to continue the conversation a little bit. Now, I know they are helpful in helping science contribute towards treatment options and cures. It's safe to say many people that consider using it a best case scenario of hope with watchful eyes, because you do have many eyes when you're doing these clinical trials.
Yeah.
Okay, so who makes the call to consider when science doesn't do a good job in reaching many of the subjects for true data? So based on what we said earlier, everybody has to have a seat at the
Mm-hmm.
table in order for you to know if the table is missing apples and oranges.
Mm-hmm.
I'm giving the worst analogies, okay, little things. But for me, I think there's definitely a break in communication when it comes to the clinical trials. Again, there's like history, if you're talking with people of color, Black people specifically, um, history, there's just
Yeah.
been a lot of crazy things that have happened, especially in this country.
Yeah.
So you understand that point of it. But then the other flip side, in all honesty, I don't think a lot of these scientists or organizations or whoever these people who conduct these clinical trials, I don't think they do a, a, a well-deserved job as really getting out there and educating the people. I think they use that as a crutch of, oh, we can't get to them. Or I feel like it's like they're here, but not really. Like if you can go and bring your team, and I know it gets like tricky in terms of like the red tape, getting actual patients and all of that. But sometimes it's not even the patient scientist aspect. It could be a caregiver.
Mm-hmm.
It could be someone in the family. Like if someone else knew of, oh, a clinical trial. And, you know, you educate this person. Now they can go to this person over here who has multiple myeloma and just educate them a little bit. Oh, well, maybe let me look into this. I just feel like the buck stops at a certain point. And after a while, it's like the same rigmarole. Oh, but the people don't want to come and, oh, they don't want to sign up for. Nobody's going to sign up. Like, you have to do some work as to educate folks, you know, as to what it is you're talking about. So what do you think more on that?
Yeah. So I think with clinical trials, it's two parts. You know,
Mm-hmm.
on the medical side of it, it is clinical trial design, um, and it's also clinical trial selection. You know, if a clinical trial is not designed to be inclusive, then certain people are going to be left out. That's just how it is.
Right.
Um, and then when you have your selection criteria, you know, if things like um, kidney function, if that's part of the clinical trial, if that's something, if you have bad kidney function, if that's going to knock you out of the clinical trial, I mean, uh, that's people with myeloma, they have bad kidney function.
Right.
So how you got to allow for that somehow.
Mm-hmm.
Um, and the other thing is education. You know, there's a lot of misinformation out there about clinical trials. You
Mm-hmm.
know, um, I'm going to be given a placebo. They're going to give me a sugar pill. That's not the case. You know, when it comes to clinical trials for multiple myeloma, you know, it's going to be testing one medication against another medication. Let's see if this is works better than this medication A added to medication A and B. You know, which works better together. So you're not going to get a sugar pill. You're not going to be a guinea pig. Those are things that we've often heard about clinical trials. And those are things that put off a lot of people because they believe that. So until we can educate people on what really happens in a clinical trial, that perception is always going to be out there. You know,
Mm-hmm.
people have to understand what happens. You know, there's different phases to clinical trials, and most people don't understand what happens in the different phases. You know, they don't use guinea pigs in clinical trials when they're testing stuff, and most people don't realize that. So it's really about education, patient education. Um, I think once people understand what clinical trials are and how they work and how important they are, that's when you're going to start to see changes in clinical trial design and making sure that the selection criteria is better designed to include everyone. You're not going to see any changes in that until those things start to happen. But education is the key. You're not going to get people that's going to be willing to participate in a clinical trial until they understand the value in a clinical trial. And for multiple myeloma, you have to see the value in it. You have to see the what's in it for me. Why should I do this? Why should I participate in this? Until you can see that, nothing's going to change.
All right. Like, again, like so many points. this is a whole conversation because I know there has to be a better way to reach people and, as you say, to educate them. It shouldn't be that difficult. However, we're in this bind where it's like a difficult conversation, and some people are just clueless as to the importance of this. You know what I'm saying? Just as I mentioned before, you kind of want to have a seat at the table, and that goes for anybody. This isn't like a black thing. This is like everybody, whether you're Asian, maybe you're not part of certain clinical trials for whatever they're doing here and there. Something I posted, whether it was this week or last week, was there's also this misconception in terms of how does this whole clinical trial works in payment. Like, does your insurance cover it? Is it free? Those are things like, you'll hear, whether it's doctors or scientists, they're like, yeah, people, they need to do these clinical trials, this and other. Maybe also part of this conversation is who pays for this?
Yeah, that's part of the education.
Right. There's programs out there that may cover the cost of you doing a clinical trial, but it's going to take some legwork to really research and figure out, is this a fit? In the case that your doctor doesn't, again, give you a script, or that playbook, unfortunately, you may have to do a little bit of that legwork. But those are some questions to ask, because I know something that I was looking at last year, and I was like, oh, okay, I didn't realize that. It was whatever the clinical trial was. I didn't realize that you had, whatever they were doing, that this was a weekly thing where they were, I guess, checking your labs, seeing what you was doing, then giving you whatever this the drug was, and just this whole continual thing. And then I'm like, okay, well, that sounds kind of costly. But then finding out that sometimes that's a cost that maybe your insurance won't cover. You know what I'm saying? So when we're going to have a conversation, we need to have the full conversation. So that way people are not, they're clueless in general in terms of this whole clinical trial conversation. But definitely, who's paying for it? Yeah, that's like number 101 as how we finish this conversation,
I think, Yolanda, a lot of that information is included in the clinical trial packet, the information that you receive, but you're going to be turned off to that because you don't understand the whole clinical trial process. So you're never going to get there to even receive that packet of information because you're already turned off. Like, no, I can't. I'm not going to be able to pay for this. I'm not going to be a guinea pig. I don't want you guys using me. So you're already turned off to that. So we've got to first educate you on the whole benefits of all of this. And I think part of the education piece, that's going to come up. These are the questions. So when you ask this question, you're going to get to answer. You're going to know whether your insurance is going to cover some of this and what kind of out-of-pocket costs you may have. What I was saying is we have to educate people to know what questions to ask when they are approached about a clinical trial. They have to know what to ask so they can get the right answers to decide if this is right for me or if this is not right for me. And every clinical trial is not going to be right. Even though everything lines up and it seems like, oh yeah, I could do that, it still may not be the right trial for you, and you have to say no, and you have to keep it moving.
Exactly. And I think through this journey, you learn as what is right for you and what isn't, and feeling okay if you say no to certain things is perfectly fine. So I wanted to move this up a bit. There's two things I'm going to skip over. So I want to hit to those who are in their 50s and 60s. So let me see. Okay, at this stage, Valarie, I'm gonna do eeny, meeny, mighty mo. Hold on. um, so, I'll, early menopause. Okay, Lord have mercy.
Yes, have mercy, Lord.
All I'm gonna say is part of the conversation, especially for women, okay, because we're the ones that would have to deal with the menopause situation. Even though I think they said that there's like a men something, so we ain't gonna go there. Men,
It's not
I
as
know
bad. They do experience it, but
yeah,
it's not as
yeah.
bad.
So men, we're gonna leave you out this little section, okay? Bear with us. So part of the conversation too, they don't tell you initially that you may have to experience that early menopause or perimenopause thanks to medically induced. Okay. Like, huh? Say what?
Mm-hmm. Yeah.
Like a medicine can actually bring you into menopause. You must be crazy. And
Yeah.
then what it does, that's like a whole other conversation. We ain't gonna spend a whole thing on what is menopause. But for the women who are on or listen later,
Mm-hmm.
okay, you can be on a specific drug, literally, and now you have to be dealing with some doggone
Yeah.
perimenopause. You know what I'm saying? So what's your take on this?
Yeah. Don't get me started on this one. Yeah. So this was I was very shocked by the whole menopause thing because when I had the transplant, it really just threw me into menopause. Like I'm talking like boom. It was one of those things that nobody prepares you for. Nobody
Mm-hmm.
talks to you about it. I started telling my oncologist what I was experiencing, and he goes, "Oh yeah, that's sounds like you're going through menopause. You should talk to your PCP about it." And I'm like, "What do you mean going through menopause?" And he goes, "Oh, when you go through the transplant and you receive the high dose chemo, kind of shuts your ovary function down." And I'm like, why didn't anybody prepare me for this? Why didn't we have this conversation? And he just looked at me like, uh, he didn't know how to respond to that. But that is, again, going back to when we first started the conversation, that's one of those things that they don't prepare you for when you get that cancer diagnosis.
It really,
Um,
like, you would prefer for it to be a playbook. Like I said again, is there's no script to this, but
yeah,
that definitely needs to be in the script.
yeah,
Okay,
because that's life changing.
it is.
That's not a little side effect that, oh, you just take something and you get over it.
No,
That's
not
very
even.
life changing. Um, so yeah, I try to tell any woman, particularly women that I talk to, that hey, this is something that you're probably going to experience. You're going to be pushed into early menopause, and talk to your doctor now, about the hot flashes and all
Mm-mm.
the other symptoms that's going to come along with that. And to go through that while dealing with decks as well,
Mm-mm.
it was just miserable.
Child.
Important, I say, ladies, have that conversation. You bring it up. Don't be uncomfortable talking about it. Ask them point blank, I hear that this may put me into early menopause. Let's talk about that. Um, it's really just having the uncomfortable conversations.
It
We
is.
don't like to have those uncomfortable conversations, but it's really what's going to make things better for you. You're going to be better prepared. And I like to think you're going to be in control. It's going to put you back in control of the situation because it's nothing like having menopause slip up on you and you not have a clue how to deal with it. So,
Child,
yeah.
let me tell you, my mom passed away like when I was really in the midst of starting treatment. But let me tell you, some things I definitely would have said. Well, I have to take that back because one of the drugs that I was on, they did give me the heads up that, by the way, that may like spin you into early menopause. So I'm not gonna lie. However, no one really explained, okay, yeah, you know what it is, but no one really explained the rigmarole that you have to go through.
Yeah.
Like, yeah, hello, I would have liked to have a conversation around one thing as a month. Okay, because that wasn't gonna work. You know what I'm saying? So, as we wrap this up, like we may have to like do another part 2 of
Part
this.
2.
But I wanted to just speak briefly about oral and dental care because that's another thing. Like I can't really go too far in to say I wasn't aware of because my team did stress the whole thing. And if you have if you have somebody, a myeloma specialist who's up on it, they will tell you certain dental work you may want to get before you start treatment and all of that, and how it's really a big
It's a
deal.
big deal.
Okay,
Yeah.
it really is.
Yeah.
And though they stress it, maybe they need to stress that a little more deeper, okay, because that's some serious stuff.
Well, I think they talk a lot about osteoporosis of the jaw, or the ONJ,
Yes.
but they don't talk a lot about just basic care. Like you can get dry mouth, and dry mouth can lead to tooth decay. You
Mm-hmm.
know, they don't
Mm-hmm.
really express that. Take, I found that a simple lemon head, the little lemon
Yeah,
head,
yeah.
that helps tremendously with dry mouth. And that can keep you from having a lot of tooth decay. Um,
Mm-hmm.
Simple cleanings, making sure that you have regular cleanings every 6 months, or, whenever you can get in there to see your dentist.
Right.
Simple things like that. Using mouthwash, biotin, things of that
Mm-hmm.
nature can help
Mm-hmm.
keep your mouth intact. But making sure that you are brushing and flossing and doing whatever you can to take care of your teeth. Those
It's a
things
big
are
deal.
so important. Um, and here's one thing that a lot of people don't know. When you do go to the dentist, you need to be taking a antibiotic before, just to ward off any kind of
Mm-hmm.
infections while you're in the chair. And a lot of people don't realize that. Uh, but yeah,
I
dental
think
care
another,
is,
I'm sorry, I think another thing people don't realize too is very important that you have to tell your doctors that you have multiple myeloma, like down to the dentist, down to the foot doctor, down to the eye doctor. Everybody has to know what they're dealing with, where they may not be, again, a myeloma specialist, but they'll know,
yeah.
yeah, child, you zipped out for a minute. Don't worry, we almost done. We almost done. But it's like so important that they have a heads up,
Mhm.
because I know for me, one of my experiences was, a typical cleaning, and then apparently one of my molars back there or something cracked. And I'm like, how does this happen? Like, what? And then find out that it may have been treatment related.
Mhm.
And that was like a whole situation where things got infected, jaw, like things would, yeah. It wasn't the jaw thing that they would tell you that, you gotta make
The
sure you do
ONJ. It
Yeah,
wasn't the ONJ. Mhm.
it wasn't that. But it was like based on the problem tooth. It was just like a whole swelling because of it was just like a hot mess.
Yeah.
And then luckily, I already told the doctor that I had multiple myeloma. So he kind of knew certain things, how to
Mhm.
go around the situation and to save the tooth,
Mhm.
which, because, honey, based on what I went through, I was like, you could have just took that, because that's kind of what
So,
brought on the infection, to be honest with you. Like the cracked tooth turned into like this whole multiple 4-month ordeal. To the point now that I think of it, I had lockjaw. Child.
Oh, wow.
So yeah. So maybe it wasn't the ONJ
Yeah.
thingamajiggy, but it was something else. So oral care is definitely top
Mhm.
priority. Even when you think you're taking care of your teeth, take care of them some
Take
more.
care of
You know what I'm
them some
saying?
more. Yes. Yes. And even I say this, most people are like, what? Even if you have dentures, you have to make sure that you're taking care of your gums
Yes.
because you can get gum disease from
Mm-hmm.
the dry mouth and stuff like that from the bisphosphonates that's used to
Right.
treat the myeloma. So it's a lot that goes into it. And again, it goes back to what our whole conversation has been about. You know, those things that they don't tell you when you're first diagnosed. And that was dental care was not something that was ever on the list, that I'd ever heard of um, at any point. So, yeah,
It's bananas.
it
All I have to
is.
say, it really is.
We got to work on
But
a checklist. All of these things, we gotta create a checklist to say, hey, you gotta make sure you're asking about this, this, and this, and this,
it
and this,
really
because
is,
they don't tell you this.
and trial and error, no one really wants to learn that way, but unfortunately, that's the way a lot of us have had to learn, trial and error. You know what I'm saying? But this was such an amazing conversation as I knew it would be. I'm sorry we didn't get through everything, but I think we got through the meaty stuff.
Yes, we
So
did.
that's a good thing. Um, yes, everyone, what they don't tell you about multiple myeloma and what you need to ask. Okay, I think this was a great conversation for multiple myeloma action month. And it's important, if it's to educate, um, things that you don't know. It's a lot of things that I continue to learn.
Mhm.
Like I'll hear, let's say my man Thomas over here, his story, and it's like, oh, for real? Like again, as I stated in the beginning, everyone's journey and story is going to be so different.
Yeah.
We've all gone through different stretches of this disease, you know what I'm saying? So it's just very enlightening, it's very eye-opening, and you have to include room to learn more,
Mhm.
and to be vocal.
Mhm. Be
But
willing to learn. I say this, be willing to learn. There are people that are like, no, I don't want to know. Just give me my medicine and leave me
mhm,
alone. And I think I personally, I don't think that's the best way to go, but I respect people who are like that, but be willing to learn. I think that's the only way that you're going to get ahead of this disease is when you are willing to learn a little bit more than what you already know about it.
exactly. And just to add, as we wrap up, I also want to say, when we have a certain energy about our diagnosis and we want to live and we want to survive and we want to do what we need to do, it brings a certain umph when our team sees us. You know what I'm saying?
Yeah,
They see that you're fighting. They see that you have the will to live.
yeah,
Then they're going to do what they need to do on their end to make things happen. You don't know how this is going to end. You don't know how, again, like I said, these meds for me may be different for you, so you just don't know. But if you come to the table and you're just kind of like, I'm gonna die, if you come with that kind of certain kind of energy,
yeah.
it's not a good thing. And I get it. Sometimes we'll soak and be in that little stage for a little bit, but it's so
Mhm.
important to get out of it because I really think that's the kryptonite to how you can beat this disease.
Yeah.
You know what I'm saying? But then that's just my little thing. I don't know.
I I agree with you 100%. I always try to look. I look at the glass as being, half full. I look for the silver lining in every cloud. I'm like, it's here somewhere. You know, you have to strain a little bit, but it's there somewhere. And I go to look for that. And a lot of people is like, well, where's the cloud? I don't even see the cloud. What you talking about?
Mhm.
So I don't know. I just believe I always say this, you know, some things happen for you and not necessarily to you. I look at this, me personally, I look at multiple myeloma as happening for me and not
Right.
to me. And that changed my whole perception on it. You know, it's not that whole why me thing. Um, and that's what keeps me going. I'm like, this happened for me. I got to just keep going with it. You know, it didn't happen
Exactly.
to me. It happened for me. So, yeah, I don't see how people,
Well,
I just, I don't
you're
know. I
gonna
just pray
have
for those
different
people
types
that
of
have that.
people.
Yeah.
Exactly. You're gonna have like a different mix.
Mhm.
That's like that could be a whole other conversation,
Yeah.
but not really because that's too much energy as even trying to figure that out. But
Yes. Yeah.
good conversation, sister. I
Thank you for
hope
having me,
you are
Yolanda.
so welcome. I can't
Pleasure
wait
to be
for you to
here.
come like the end of the year. You're scheduled to be a guest,
Yeah.
so that way we can hear more about your story. Um, this was amazing. So everyone, as I say, don't forget to go to the bio, go to YouTube, subscribe to No Better Time Than the Present. I'll have the replays up in a couple of days, and use this particular episode as a nice teaching lesson. I think this special was definitely good in terms of giving you some tools to think about as you speak to your doctor about certain things that you probably didn't consider before.